Hi, everybody. Good afternoon. Welcome to this Care Transitions webinar. Can everybody hear me all right?
Yes, we can hear you.
Okay. Today we'll explore Southwestern Vermont Medical Center's Transitional Care Program and consider how some of the learning and program elements might be adopted or adapted into your own efforts. Before we get started, I'm going to quickly review a few housekeeping items. The call will be recorded. The recording will be available within a few business days on our website. Phone lines will be on mute while the speaker is talking, but we will unmute the lines after the presentation for questions, and I'll give some instructions on how to ask questions at that time. Although the lines will be muted, we would still like you to actively participate during the session by using the chat function. Next slide. My colleague Stephanie Baker will be monitoring the chat window and responding to your comments in real time. Don't be shy. We would love to learn more about your efforts and how we might best support your going forward. And we'd also love to hear your thoughts about what the speaker is saying. So let's try it out. Let's see who's on the call. If you could type in your name and your role, your organization, maybe the state that you're listening in. And over the course of this session, we'll use that chat feature to call out things that resonate with you. Challenges you've encountered, how you're addressing them, and any questions that you may have for the speaker. Next slide, please. Today's speaker is Richardson, who is a clinical nurse specialist and master prepared and works at our transitional care program at Southwestern Vermont Medical Center. She was recently awarded Magnet Nurse of the Year in 2016, and this award was in recognition for commitment to structural empowerment within the facility. I think you'll be very interested to understand how the transitional care program has impacted the community and really taken admissions and readmissions down a notch in that community. So without further ado, I'd like to introduce Barbara Richardson.
Thank you, Gail. I'm very happy to talk to everybody today about our transitional care program. I love to talk about it, and so I'm very happy to also understand what others are doing with transitional care in their communities. So I hope that there'll be lots of interaction. Next slide, please. Okay, so
Barb, just when you have access.
Yeah, I've got it. Thank you. So just to put a little context around us, we are a very small rural community hospital in the southwestern part of Vermont on the border of New York and Massachusetts. So our catchment area is all three states. A wide geographic travel location. The nearest hospital from us, both north, east, and south, is over an hour away. So our patients travel a long distance to get to acute care. Also, the state of Vermont, just so you're aware, is the second oldest state in the nation according to 2010 census data, and our county is the oldest county in the state. So we have a very old population and a relatively poor population. The hospital itself is 76% dependent on Medicare and Medicaid reimbursement. So that gives you a sense of how old and how poor we are. The good news, however, is that we are highly embedded with advanced primary care medical home practices. 90% of our primary care practices in our catchment area are NCQA certified. Okay, so our journey actually started in 2012 when we started hearing more and more about healthcare reform, and we saw things happening. We saw hospitals being penalized for readmissions and poor outcomes. In our particular area, rural America, we were seeing hospital census going down, inpatient census going down, and outpatient business going up. At this point, 78% of our business was now in the outpatient arena. We also saw patients who were totally overwhelmed with the complexity of healthcare and the systems that they were trying to maneuver through. We saw acute care length of stay decreasing to the point where people were being sent home still relatively ill, and so early that there was not a lot of teaching done. So helping people become familiar with some of the things that they really needed to know to be able to take care of themselves at home just wasn't happening the way it had been. We all know that there's silos of care in healthcare. No different here. We were seeing primary care practices that were not getting information timely from specialists. We saw ED docs not being able to access primary care information either because computer systems don't talk or with off hours. A lot of people trying to put together good plans of care for patients with a lot of black holes, a lot of unknown information because of these disparate, fragmented systems. So a lot of times you were discharging patients just hoping that they were going to be safe. So as clinical nurse specialists in this acute care setting, we were trying to think about what the future might hold for us in the context of what I've just been talking about. And just so you're aware, we were extremely fortunate in this organization that we had a clinical nurse specialist embedded in every inpatient unit, plus the ED and the OR. A highly rich inpatient resource in a setting that was decreasing census. As more healthcare was shifting toward the outpatient and community setting, we were seeing the writing on the wall. We were also at this time, 2012, in a state where our governor was pushing very hard for single-payer platform. We were in the midst of joining an ACO and really didn't have too much of an idea what that might mean for us. Our state was talking about moving away from fee-for-service toward global budget, and our organization was volunteering to be the first hospital to take that big step. So there were lots of unknowns, lots of moving parts, and with lots of change happening, we thought this might be the ideal time to actually add another change into the picture. So we had a little brainstorming session, the CMS did, to try to think about what we could offer the organization and our patients that would have meaningful impact. We had heard about Mary Naylor's transitional care model, and that was something that we wanted to talk about, but we didn't have a lot of information. So like all good CMSs, we did a lit search. And we found that there really were several models of transitional care out there. And important to note is that all of them have their strengths and limitations. You really just have to find the one that meets the needs most closely of your organization, your community, and your patients. And we felt after looking at them all that Mary Naylor's model really was the one that best met our needs. We liked the fact that she used advanced practice nurses, because that's what we were, and it also demonstrated excellent outcomes. The interesting and a little concerning part of her program was that her research had been done many, many, many years prior, but had not been widely adopted, mainly, we think, because in a fee-for-service environment, her program was intended to keep people out of the hospital. And in that fee-for-service environment, people out of the hospital meant decreased resources for the hospital. And so we think that that was part of the reason, at least, why it didn't expand as much as it seemed like it should, because it was a wonderful program. But now, with the triple aim of reducing costs, improving quality, and patient satisfaction, we felt it was the right time and the right fit for the available CNS resource. They have, the University of Pennsylvania, where her work was done, has a 6-week online program that we all enrolled in. It's presented by a practicing transitional care nurse, and we got to benefit from the knowledge of these professionals, as well as Mary Naylor herself, who was at least part of the learning process for us. So we had made the decision at that point that we were going to go forward. And luckily we had a very visionary, forward-thinking executive leadership team here who were on board with us right from the beginning. At CMS, we had to do a pretty big role shift. Having been acute care nurses all of our lives, had to start thinking about how we would function in a very different setting where we really had, none of us had actually practiced before. So we relied on some of our community colleagues to help us, and despite some trepidation on their part about our program, we're a small enough community, we know these people, they know us, and they did open their arms to help us with this. But one of the first decisions that we had to make about our program was how would we structure it? Would it be a disease-based program? Would it be a program based on primary care practice? Would it be a geographic program? How are we going to get our patients and know that those were the ones that we wanted to follow? We decided not to go the route of a disease-based program because we felt that would limit us too much. We're too small an area for that. So what we decided was that the primary care practice is really the center of community health care, and that's the route we needed to go. Our patients, and I'm sure your patients as well, in small communities out there have long and strong relationships with their physicians. And we wanted to augment that and not do anything that might interrupt or disrupt it. And having worked for many years, all of us in this organization, we were, the docs knew us, the MTs knew us, and so a relationship already existed. We just needed to build on that. It was hugely important that we communicate our plans to our community colleagues. It was, there were certainly concerns on everybody's part about what we were planning to do, why we were planning to do that. There were lots of questions. But I'll tell you that this is what our community resources looked like at the time before we actually started. There were a couple of visiting nurse agencies. There were primary care case managers, the subacute rehab nursing home, primary care practices itself. And these were all smart, caring, committed professionals doing the best they could in a fragmented system. But nonetheless, gaps continue to exist. Patients were feeling unheard. Professionals were frustrated. So we could only build from there. One of the first ahas that we had was the realization that the hospital is not the center of the universe. As acute care nurses, we thought it was. And what we realized was the majority of healthcare takes place out in the community by non-professionals who are unpaid, and it's amazing. It was really an eye-opener to us. I mean, abstractly, we probably already knew it, but until you actually saw it happening, you didn't really own it. And so what we realized is patients have more control than they think they have. They can decide if they want to follow a medication regimen or not. If they can decide if they want to seek health care or not. And so even though it's a low acuity setting, there's a high degree of control by the patient and or their family. So we wanted to build on that. We wanted to help our patients see that they did have control, because control gives power and information gives power. So that's part of our background philosophy in empowering our patients, is helping them to see and have their voice heard. So I don't want you to think that everything went totally smoothly right from the beginning, because it didn't. We tried very hard, very early on, to share and be truly transparent about what we were doing so that we could mitigate what we already knew would be some challenges, the turf issues, are we duplicating services, et cetera. So we started out with lots of meetings. We met with the docs. We met with the office nurses, the visiting nurses, the short-term rehab nurses, anybody who might think for a minute that we're trying to step into their shoes or onto their turf, and try to explain what we were doing. We probably didn't explain really well because at the beginning we didn't know what we were doing. There was no roadmap here. But nonetheless, we tried to be as open and transparent as we could be. The one group of people who were most concerned about our program were the medical home case managers who really felt that they were doing the care coordination for people in the community. And they were. There is no doubt that that is exactly what they do. But what they didn't have was eyes in the home. And that was the one thing that we could offer that was different than what anyone else could offer to a majority of patients. Now, certainly the home health nurses can offer that, but to a relatively limited group of patients. So after lots of meetings, lots of work to discuss and understand each other's workflow, we finally got through that, and we have wonderful, wonderful working relationships with them now. The other question that we heard on a fairly regular basis was why advanced practice nurses? And we feel that as clinical nurse specialists, we're educationally prepared to see the big picture. We're trained as systems thinkers and problem solvers. That's what CNSs do. So we have a skill set that allows us to critically think in a broader manner. And having been nurses for many, many years, we had a confidence in our ability that would serve us well as we started to build a new program and to sell it as well. So this is a schematic of what our program looks like. We very specifically wanted to put the primary care provider and the patient in the center. So you'll see that's exactly where they are. And our relationship with the patient will come through their relationship with the primary care provider. So each transitional care nurse is assigned to very specific primary care practices as their transitional care nurse, so that you become part of that primary care team. The patient sees you that way. The primary care practice can see you that way as well. And then from there, we'll branch off to see those patients anywhere they happen to be. We'll follow them totally across the continuum. We'll see them in the hospital. We'll see them if they go to short-term rehab afterwards. We'll see them if they go home. In all the different settings, we bring information, we bring up care coordination. We help to build what is not just an ideal care plan, but a realistic care plan, one that, based on what we know of the home environment, will actually be workable for everyone. The program that we've built is time limited. We're seeing patients for maybe up to 3 months. We try to get into the home within 24 to 48 hours of discharge from the hospital, and most of the time that does happen. We coordinate and facilitate to make sure that duplication does not take place. And we refer patients as needed, either to community programs or to the visiting nurses. They actually found that their referrals went up because of us. We're not going to hold on to people just to keep them in our program if what their need really is home health. And you know, they say timing is everything. Right as we were sort of finishing the build and thinking about getting ready to start, our chief nursing officer got a call from one of the primary care practices in our catchment area saying that they were involved in a CMS Demonstration Project that included looking at improving transitions, and was there anything she could do to help. So it just fell into our lap at the perfect time, and that's exactly what we did. So this is the first group that I partnered with. They are a great group of practitioners who are so open to this program. The goal of the transitional care program was to focus on their most complex, chronically ill, high-risk patients, following them across the continuum. looking mostly at disease self-management so that we could help patients truly understand not only their disease but their symptoms and how to interpret those symptoms and then what actions to take based on those symptoms. Another big piece that the primary care practices were most concerned about was medication management. They worry a lot about what their patients are doing with their medications at home. Do they understand? Are they changing things? Lists are never correct. They never match. So we try to build some congruity there as well. And then as well to evaluate what social needs are and connect them to the appropriate resources. So the focus, again, primary care, and that's how we see how we get our patients. And one other thing that we do that was not original in our program, we didn't anticipate this, but we found that the docs in the primary care practices were asking us to see patients who had never been hospitalized, but whom they were worried about, that were failing at home, that might be at risk for hospitalization. So we did take that on and find that, it's kind of hard to measure objectively, but we think we've been able to actually prevent some index admissions. So how did we do this? How did we get all these FTEs to build any kind of a transitional care program in this healthcare environment where funds are not great? We did it through redeployment of existing resources for the most part, and what we couldn't get that way, we got through grant funding. So there were no big FTE explosion here. We took a really strong look at what was available in the inpatient environment, which was a shrinking environment, but a well-rich resourced environment. And how could we maneuver things into the environment where more care was taking place and less resources existed? So this is a story now about how we grew our program. It started out as just 3 transitional care nurses, and what we found very early on was that there were so many social issues going on that it was beyond our ability to do both clinical and social on so many of the patients that we were seeing that we needed the expertise of a social worker. We were lucky to be able to get, through redeployment of resources, a 0.5 FTE social worker who could really focus on a couple of things. Some of her focus is carrying on what was being initiated by the inpatient social workers and sometimes would drop when patients left the building. And their length of stay were so short that happened more than we liked. So she's able to close that loop. But as well, she's able to start fresh with people who had never been seen by inpatient social workers and just work strictly with our transitional care patients. That was number 1. Number 2 was clinical pharmacists. Medications are a big, big issue. Med reconciliation, understanding of medications. We were seeing a fair number of readmissions for people who were coming in with medication-related misunderstandings, a lot of them being anticoagulants, new insulin, or some form of cardiac medication. So we were able to redeploy some hours of our clinical pharmacists, this group of 4, volunteered to be the ones who gave some of their hours to transitional care. So their focus mainly is seeing patients in the hospital, doing education on anyone who was starting on a new relatively high-risk medication, going to be going home on one. But also they're able to give us a few hours to come home, to patients' homes with us, if we find that's a need. Now, we don't use them a lot for that, but at least they're available should we need that. And when we have needed it, it really has been a remarkable resource for us. When we first started, the primary care practices tried very hard to give us their behavioral health and substance abuse patients to do something with. It's a group of patients that really confound everyone. And we tried. But, you know, this population they don't have their needs best met by a short-term, time-limited transitional care program. And during this time, it was in 2013, one of the transitional care folks had been to a Magna conference and heard about a program in Connecticut that had built a community care team program to deal with these high ED users. So we visited them and we replicated their program here. And it is a program based out of the ED where there is a once-a-month meeting of a broad group of community resources and inpatient resources. So it is inpatient social workers and some of the care managers, as well as outpatient. We have social work, Medicaid case managers, staff people. We have both rehab, economic rehab. We have transportation, housing. All of these people sit in a room together, and with a patient's consent, we get an informed consent from them. We present their case, and that whole team builds a wraparound support network for these patients. And though our numbers are small, we've only seen, at this point in time, the data unfortunately is a year old, we had only seen 25 patients, but we got a 40% reduction in their ED use in a period of 2 years. So it was, a year and a half. It was from, that would have been a half a year, I'm sorry, from July of 2015 to January of 2016. And so we think that's a great start. We're a little sluggish on data right now. We're changing our system so we don't have updated data, but we anecdotally feel like we're holding the gains on that, seeing a lot less. Their needs really were basic, but it required a community really to take care of these folks. So we really like this program. Next, we have a fair number of diabetics in our catchment area who were having some trouble with their hemoglobin A1Cs. We did have one RN CDE embedded in 3 of our medical home practices, and this is her data. We have since then been able to redeploy a resource of an existing RN CDE who was in another position, and we redeployed it to have her help cover some of the other medical home practices, as well as seeing new diabetics in the hospital. And she does do some outpatient visits as well. She'll come out to homes with us if we need her. Again, that's not a resource that we use a lot in that way, but it is available to us if we need it, and have had a 10% reduction in hemoglobin A1Cs with new data soon to be published. We have a large population of COPD patients in Bennington County and the catchment area, and it actually, the readmissions of COPDs exceeds heart failure in our area. And there was no outpatient resource for these folks, even though, it's widely published how effective pulmonary rehab is. So with the transitional care nurses seeing a really high number of COPD patients, we were able to lobby for an outpatient resource, and through redeployment of resources, we were able to get some FTE time from rehab and respiratory therapy to hold a 8-week pulmonary rehab program, and have had really tremendous results. Again, numbers are relatively small. This is January 15 through December 2016. We saw 77 patients. 71% of them completed the program. And of the ones who completed the formal program and then joined the maintenance program after the formal program, 0% readmission rates for 3 months. Now, that's a lot for COPD patients. So it's really been a wonderful resource. Patients love it. They love the way they love cardiac rehab. They love the socialization as well as the education that they get. This is the metrics that they are using to determine success. They look at dyspnea using the UCSD, the University of California, San Diego Shortness of Breath Scale. They look at quality of life using the St. George's Respiratory Questionnaire, and then activity ability is through the functional walk test of 10 meters and the 6-minute walk test. So they've had good success. Now, the one resource that we were not able to just do a redeployment, this was a grant-funded resource, was an Interact coordinator for our local nursing home. We were finding that a good third of our patients were coming back from the nursing home at one point in time. That number slowly went down, sort of on its own, but not anywhere near where it needed to be. So we hired an Interact coordinator. Interact, for those of you unaware, is interventions to reduce acute care transfer. And it's an evidence-based program that is structured to give information to the CNAs or LNAs at the bedside to recognize subtle changes, and then a structure to put into place to address those subtle changes so that interventions can be started early, or recognition can take place early, and then interventions can be put into place early, often in the form of increased surveillance to try to ward off whatever is happening before it becomes an issue that requires hospitalization. And in a 6-month period of time after getting it fully implemented, they were able to reduce readmissions from 17% down to 2%. So that was pretty amazing. And the LNAs love it. They love being a part of that clinical team that has specialized knowledge and having the power to really see something better for their patients. And in addition to just doing the actual Interact, at the same time, aside from that, there was also an effort to increase course form completion, to better schedule patients who needed to come over to the hospital for scheduled testing or blood transfusions, as well as an effort to start palliative or hospice care early on, and we're not good at that. We've still got a lot of work to go there. The other thing that was happening at the same time that we were building this program was an improvement in our interdisciplinary round. They started as just a very small group of people, not even including nursing, to try to build discharge plans for patients. And it has now grown to a team of nurses, case managers, social workers, dietitians, respiratory therapists, physical therapists, clinical coordinators, and even the hospitals are coming now. So we have a really vigorous, robust program of building discharge plans that are real and make sense, and everybody knows about it, which is so important. We go as well, at least one of us tries to be there every day, and they are held every day. Every patient in the hospital or on the med-surg critical care area is discussed and a plan is built, and we get about 48% of our referrals through this program. Now, I want to talk to you a little bit about our specific data, the transitional care nursing data. We looked at readmission. That's the way that we thought we could best define whether or not we were being successful, at least initially. So what we look at is the day that we first start interacting with our patients. And then we look back 6 months and forward 6 months. And we look at ED admissions within that prior to us 6-month period, and ED visit after we started intervening with the patient. And we found we've been able to reduce, this is our latest data, ED visits by 18%. So that's pretty significant. We like that. And I can skip that one. This is now looking at our inpatient and observation readmissions. Again, same time period, 6 months before and 6 months after, and we were able to reduce inpatient or observation stays by 52%, so we're very happy with that. However, it's not good enough. We would like to see if we can close the gains a year out. Now, that's relatively ambitious for the population that we see who is really chronically ill, quite frail, and so on. But we're in the process of trying to get that information now to see where we stand and what we might be able to do to get there. And so this is just a review, sort of our fresh eyes coming into this, seeing things that had become so commonplace that you maybe don't even look at them anymore, or you know they exist, but we're so frustrated by your inability to make gains that you sort of stop. Well, it's fresh eyes going in. We were able to pick up some of those things and run with them. Big one being the standardized education. We were finding that patients with chronic diseases were getting a lot of information from a lot of different places, and some of it conflicted, and they were confused and didn't know what to do. So we really worked hard to get a standardization of disease education. So that means using the same tools that use the same words so that they're not confused. They see the same thing the same way each time, given by all practitioners. That specifically I'm talking here about COPD and heart failure. Those are the two ones that we focus on the most. So we use the same teaching materials across the continuum. We use the same stoplight magnet across the continuum so the patient hears the same thing and learns the same thing over and over again. Med reconciliation, again, being a big piece that we focus on. There's so many reasons why people are not taking what their docs think they're taking or are not telling us what they're taking. So that's going to be an ongoing challenge. If anybody has good ideas on how to fix that one, please raise your hand and let us know. So that's that. That's all I wanted to say about that. This was, as I mentioned possibly before, one of our big ahas as well, that 20% of our care would be clinical and 80% would be social. We did not see that coming when we built the program. We were very naive, thinking that we were going to just be really focusing on chronic disease education, but we find that social comorbidities really impact health behaviors in a way that makes it impossible to manage your own health if you're worried about so many other things. And without trying to be too dramatic, I want to say that we had no sense that we might be seeing a frail, elderly, chronically ill couple in their early 80s who was trying to raise their 10-year-old grandson because their daughter's in jail and the kid's father is dead from a heroin overdose. I never pictured that in my worst dreams. I had no idea that people really had so little food and so little access to it, and so limited funds. And, you see the world through your own little framework, and my eyes have been opened very wide, and I'm seeing things that I didn't know existed. Others might have, but I didn't. And so this was a big, big aha to us. And while I'm talking about this, food insecurity is probably one of the big things that we found in our community. Not that there was no food necessarily, but there was limited food or limited access to healthy food. We are a rural community that has 3 grocery stores. They're all in sort of one part of town. One of them is really out of town, absolutely not walking distance. One of them could probably be walked to by healthy people, but not by frail, older people. So if you don't have a car and you don't have a way to get there, then, potentially you're going to the convenience store down the street where there's really no healthy food, and it's expensive, and so there's lots of problems with people having access the way they should have to healthy food. So I'm not going to talk about all these, but there's a couple I want to highlight of projects that have come out of our recognition of food insecurity in our area. The Grateful Heart program is the first one. And that was actually started by the husband of one of our transitional care nurses who heard us talking about food insecurity and thought, I think I know how to fix that. And he did. So he met with local farmers and our dietary folks here at the hospital, got them together so that farmers are donating produce that will either not be sold if they grew too much, if it's overage, they don't know what they're going to do with it, it's going to rot in the fields. And this fella works with troubled youth at the high school. They go out and pick and bring the produce to the hospital. We're volunteers in our dietary department, turn it into soup and freeze it, or turn it into bread and freeze it, where it is then dispersed out to our local community food pantries of whatever sort. So food kitchens, Meals on Wheels place, that kind of thing. So that's a wonderful program. And it's a win-win for everybody. Everybody feels good about doing this. The other one is our campus food garden. It's just a small garden, but the kids in daycare help out with it, and some of the some of our employees help out with it. And the food is then donated to our transitional care program to take home to our patients. So that's a wonderful thing as well. And it's a way of getting fresh produce that they might otherwise not get. And one other thing is a program we call Go, which is a van of fresh vegetables that come to our site from, again, local farms once a month, and people can come with a tote bag and we will fill it with fresh produce so that they can at least have some freshness, and it's totally free of charge. Anybody can come and get it. And so those are the three that we really are most proud of. The other, I'm not going to spend a lot of time on, just know that housing and transportation are two big issues that we have not found meaningful fixes to. Now I want to just talk a little bit about why we think we were successful, what kind of things factored in that made this a successful program. And the first is our culture. We are a fourth-time magnet designated facility, which I think speaks volumes to the culture of this organization that has so embraced this transitional care program. Our organization really encourages interaction and work between departments and entities in the organization for that really single collective purpose of providing excellent patient-centered care. We're supported to use evidence-based guidelines. We're challenged and motivated to work to the highest level of our potential. And so it just allows us to grow and to think and to explore and to change. Communication is the next one, and I alluded to that earlier, that communication is the most challenging element of this and the one that took the most time and effort and the one that still requires time and effort. It was so important to communicate and be as transparent as possible as we went through every step of the build of this. Almost 4 years later, we are so fully engaged with our community partners that it's really quite refreshing. However, it still requires time and effort and work, and we consider it time and effort well spent, however. Creativity is really encouraged in this organization. And, back when we first started, there was no roadmap, as I said before. We didn't exactly know what we were doing, where we were going, how this was going to end up. As we were doing it, we were building it, we were, flying on a wing and a prayer sometimes. But we had good facts, we had good evidence of a base. And so, we felt like we had the skill set and the knowledge to really reasonably build a program that had the potential for success. We didn't know if it would be successful, but we knew that we had the potential. And we also had a team of people that had really very different skill sets. And I don't necessarily mean clinical skill sets, although we all have different skills in that as well. But we have people on the transitional care team that are sort of visionaries, the dreamers. We also have some that are the concrete thinkers that can really bring us back down to earth when we need to be. And we have people who can take an idea and operationalize it without a thought. So having that skill mix really made for an active, vibrant, robust team. And then lastly, I just want to end with a few of the lessons learned and things that I hope you can take away when you're trying to build your own program. And that is that partnering is very, very big. We could never have done this alone. Having partnered with our community colleagues, with our physician colleagues, it was so vitally important to the success of this program. And the beauty of developing partnership implies a relationship and a common goal, which says volumes to our patients as well. They see us as an integrated part of a team that really cares about them. And the more people in the partnership, the more opportunity to solve problems and fill gaps and provide really the best possible outcomes for our patients. We believe in magic. Timing is everything. Things fell into place for us right from the beginning, whether it was luck or knowledge or positive attitudes, I don't know, but it worked, and I believe that it can work for you as well. You just have to embrace the opportunity for change. You have to stretch a bit out of your comfort zone, but believe in yourself, believe that you have the potential to make a significant difference in the lives of your patients and your families, and you will. So what lessons did we learn? I think, first off, expect to stumble. You can't do it perfectly out of the gate. You learn from your stumbles, and that's okay. It makes it a better product in the end. The other one, the big one for us, is develop an elevated speech, a short, concise way of informing others about your program. We didn't do that. I think mainly because at the very beginning we didn't know exactly how to describe our program. But once we got it and got it all together, having that succinct and consistent message, we think strengthens the credibility of our program and less room for misinterpretation. The other thing is try to build some credible criteria and stick to them. Be flexible. You can't never step outside of that, but having some structure helps others to better understand who they should be referring to you. And then one other thing is to not dismiss the idea of single visits post-discharge. So not all of our patients get what we define as transitional care, which is, many visits post-discharge over that period of 3 months or maybe 2 months. Some people just get a single visit. We never actually built that in initially because that's not what we intended, but we find that so many of our patients are truly vulnerable when they go home. They're elderly, they're overwhelmed, they're fatigued, they're confused about their medications, they make mistakes, they don't hear what people are saying to them at the discharge process. So many errors can be mitigated by a single post-discharge visit to help people get their appointments scheduled or ensure that they are indeed scheduled. to make sure that meds have been picked up from the pharmacy or there's a plan to get them, and just helping them understand some of the things that they maybe didn't understand when they were going through that sort of distressed discharge process, when they're thinking of just getting out of the hospital. One of the biggest lessons we learned was the extent to which patients' unmet basic needs can really impact a successful transition going home. We saw really firsthand the day-to-day struggles they face that we didn't know about at first. We didn't know that. They don't necessarily share the kind of information that would help you to know that to the inpatient staff. It's not until you actually are sitting in their living room with them that you build that relationship that allows them to give you that kind of information. And so embrace it. It's a privilege, and this really has been a program that we are so happy to have not only built, but to actually be functioning in. It's a truly rewarding program. So with that, I am going to say thank you. After this program is over, you can feel free to contact me. This is my contact information. But for right now, we'll open it up to anybody with questions.
Thanks so much, Barbara. That was fantastic. I was wondering, just for the sake, if you wouldn't mind advancing to the next slide.
Certainly.
Fantastic. And I think you did a great job highlighting the key takeaways. But just if I could summarize, evaluate the true needs in your own community. They may not be the same that you've found. If you're only focused on the clinical aspects, you are missing the full picture. You found that 80% were not clinical. That it's critical that you're identifying gaps in care, and that partners, even those that you didn't necessarily know existed, can make all the difference in the world. And finally, and this is an area that you're continuing to focus on, tracking progress and sharing findings. Can you go to one more slide, please? Mm-hmm. So we do want to hear from you, and I know that we don't have a lot of time, but I would like to open the phone lines. I'm wondering, Morgan, can you remind the callers how to do that?
Sure. To unmute yourself, if you would press #6 on your phone, and then also make sure you didn't manually mute your line as well. Again, that is #6.
Thank you. And while we're waiting for the first person to chime in, I'm wondering if Stephanie, if you wouldn't mind sharing one of the questions from chat. I see a bunch coming in.
Yes, we do have a number of questions in chat, and the first one was, how did you deal with behavioral health diagnosis? Were there any issues with getting patient consent to discuss with the community care team?
Actually, what we did, and I didn't say this, was we, through grant funding, hired what we titled a patient advocate who was based in the ED, her role is to interact with these frequent ED visitors who have a behavioral health or substance abuse issue, and ask them if they would agree to be a part of this program. Now, it sometimes takes multiple conversations before they'll agree. Some people are very open to it right away. A lot of them have questions. They're concerned about HIPAA and who's going to know their information and so on. But in general, the ones who have been the highest users have pretty much agreed to allow to have their case presented. So it's not been a huge challenge. Probably the most important part was having someone whose job it was to do that consistently.
Fantastic. And before we go back to chat, I just wanted to see if anybody was on the phone line. Hearing none, I want to make sure we get through some of the questions on chat. If we don't get through all of them, please know that we will summarize them and share them with this group. Stephanie, can you let us know next question, please?
From Judith, she likes that you have the standardized education materials for patients with COPD and CHF to promote patient knowledge and adherence. Are you going to be offering the same materials for other chronic conditions?
At this point in time, we don't have a plan for that. We started with heart failure and COPD population because that was our biggest group of patients in this particular catchment area. So, no, the answer is no for right now. It doesn't mean that we won't in the future, but we are pretty much sticking with that.
Great. And Stephanie, I know Jen Thiessen has a few questions about sending people into the home.
Yep. Did you encounter any legal or risk barriers that you faced when you implemented the home visits? And also, what was the cost of the mailer training?
All of this went through our legal team, and we have a very specific consent form that we ask patients to sign that, basically says they're allowing us to come into their home, they're allowing us access to the medical record, they're allowing us to talk to their physicians, and so on. The sort of general stuff that's in consent, plus they have to put away unsecured firearms and vicious dogs, that kind of thing. Otherwise, there really were no barriers. And for the mailer program, it was quite expensive. I'm going to guess, I remember that it was close to $6,000 per person. Or maybe it was for all of us. If I know who you are, I can get that information to you. It's still an ongoing program being offered, so you can probably find it online.
Thank you. And Steph, I think we have time for just one more question.
Sure. There was actually just one quick question, too. Can you share a copy of the consent form?
Oh, absolutely. I'd be happy to. It's not a problem.
And then I think the last question, so does the TCN share or have access to the inpatient and outpatient EMR?
Yes. We have access. We actually document our findings in the inpatient physician module of the medical record, and then it is sent out to the primary care practices the way an H&P goes out to them or a consultation goes out to them, et cetera. We also have access to most of the EMRs of the primary practices that we're associated with, which are disparate systems, which makes it a little difficult, but we do, yes, have access to most of them, not all of them. And the ones that we don't, we just work with their office staff to make sure that we get problem lists, medication lists, et cetera. But most of our owned practices are all coming under a single electronic medical record very soon, which should make everything a little bit better, a little easier for everyone.
Yes, it would. I think all of us would love that to have. But it sounds like the partnerships are also really helpful. Thanks. Can I advance the slide one more time?
Sure.
Thank you.
Well, not going. Hang on.
Technology is a lovely thing when it works.
There we go.
So I want to thank Barb for sharing her experience and being willing to connect and provide tools and resources. I would just encourage those of you who are participating in today's session, if you're interested in learning more and connecting with others within your state to improve care transitions, the QIO is happy to help. On this slide, we've listed the care transition state leads in each state, and they would be more than happy to connect you with others who are looking to solve the same issues. And I'm going to have Barb, if you wouldn't mind going one more slide.
Maybe. Okay, there we go.
Thank you. And then the last part that I have is the QIO is working with both long-term care facilities and also community partners to improve antibiotic stewardship. And we have a few upcoming training sessions, webinars for you to learn more. And they are listed. The next ones are actually long-term care and for community providers are on March 28th. All information, including the archived webinars, including this one, will be on our website. Again, I want to thank you, Barb, for an excellent presentation and your willingness to share what you did in your learnings from the program. If you have questions that you put in chat, we will certainly address them. But again, Barbara has shared her contact information. Thanks to all for your participation, and have a fantastic day.